We have our final speaker, and I just wanted to make sure to say thanks to everyone for coming. We're really excited that you came, and including those who are listening online, and hope that you've learned a lot today, and I definitely have, and it's been a great program. Thank you again to Nicole Leith for organizing everything, and to all of our sponsors and community partners. So now I'm going to introduce Dr. Samantha Holden. She is a neurologist who has fellowship training in both movement disorders as well as behavioral neurology. So she has a big interest in different conditions that cause problems with both thinking and memory, as well as with movement. And so she's going to talk with us today about the atypical Parkinson's or Parkinsonism beyond Parkinson's. So look forward to her talk too. Thanks very much.
Thank you, Dr. Amara, and thank you so much for sticking it out to the end. Hopefully, this is a nice overview for some of the alphabet soup of the other types of Parkinsonian conditions that can happen, that we as clinicians are always kind of keeping one eye open looking for, because sometimes people can come in looking for all the world like typical Parkinson's and things can change. Or people can come in looking like another type of condition, like Alzheimer's or the other things I see in my memory disorders clinic. And then these other features can emerge over time. So every single time we see you in the clinic, we're second guessing ourselves, rethinking things, making sure we're not missing anything. And as Dr. Kern also alluded to, as technology's changing and biomarkers are becoming more and more common and less invasive to obtain, that if there's blood tests that are going to be available in the near future to tell us more clearly what's going on inside somebody's brain without having to wait until we can get a little piece of it under a microscope, which we're not taking any pieces while anybody would miss them. And so waiting for autopsies to be sure of what diagnosis somebody had is unacceptable. And so as these things are coming out very, very quickly, just 2 months ago now, there was a new blood test approved to tell us the likelihood of Alzheimer's plaques in the brains of people with that condition, where we don't have to do invasive tests like lumbar punctures. So if I give this talk again in the near future, it might be different. But the point of this conversation today is to give you the big picture of the types of things we're always looking for to see if a Parkinsonian condition is not Parkinson's disease. Here are my disclosures. I'm the director of our Lewy Body Dementia Center of Excellence, grant funding, and some advisory panel work for cognition therapeutics, specifically for drugs for people with dementia with Lewy bodies. So this is a review, I'm sure, for everybody in the room today, but just to make sure we're all on the same page, Parkinsonism looks like Parkinson's, doesn't necessarily have to be idiopathic Parkinson's disease. The bradykinesia, slowness of movements, or akinesia, which is so slow it's not moving at all, and that the important differentiation from other types of motor disorders, things like ALS or Lou Gehrig's disease, is that the strength is normal. So the person is strong. The body's just not listening quickly enough. It's not doing the signals that the brain is sending through in terms of moving the body quickly, easily, automatically. Freezing of gait, which is under the umbrella of akinesia, and rigidity, the tightness of muscles and the resistance to passive movement. Under hypokinetic, less movements, apraxia, which we'll come back to as we discuss some of these Parkinsonian conditions, is again, the person is strong, but the planning, the programming of doing those skilled motor movements, using tools, for example, is impaired. So this very messy series of umbrellas all overlapping each other, and the terminology that we use is confusing. It's confusing even for neurologists in this field. But the broadest umbrella of that Parkinsonism, it looks like Parkinson's, slow, stiff, and/or shaky, can be primary neurodegenerative diseases, but it can also be what we call secondary Parkinsonism. So something else is getting in the brain's way. It's not a brain change inherently causing those symptoms of slowness, stiffness, and shakiness. So blood vessel changes in the brain very commonly can make somebody look like they have Parkinson's disease or one of these other conditions, but it is from the blood vessel changes in the areas important for controlling those movements. medication-induced Parkinsonism, most commonly either medications for psychiatric conditions that actually work by blocking dopamine, or for nausea and vomiting, which also work on the dopamine systems. And sometimes even if the person's not on those medicines anymore, it can still cause the Parkinsonism years down the road. Now, the tauopathies. So tau is a protein that can build up inside the brain. We don't have a way to see that yet, though that's one of the biomarkers that hopefully is coming in the near future. Progressive supranuclear palsy, or PSP, and cortical basal degeneration, or CBD, are Parkinsonian conditions. They cause Parkinsonism, slowness, stiffness, and shakiness, but they have a very different protein in the brain than people with Parkinson's do. Tau rather than synuclein, that other smaller umbrella to the right there. And then multiple system atrophy, the third condition that we'll discuss at the end of the talk, is also an atypical condition, but also has synuclein, like people with Parkinson's do. So this gets very complicated very quickly. The smallest umbrella of Lewy body dementia is somebody that either started with Parkinson's disease, slowness, stiffness, shakiness, primarily trouble moving their body, and then at least a year later started getting thinking and memory trouble. Why 1 year? Made up. They just picked a time point. As opposed to dementia with Lewy bodies, where the person started with thinking and memory trouble with or without the Parkinsonism. These terms might change very significantly with these biomarkers coming out, because right now there's no way for us to tell the difference between who has Parkinson's disease dementia and dementia with Lewy bodies on any tests. The only difference is what came first, what's more prominent and bothersome, what led that person to seek medical attention. Usually people who end up with me in the memory disorders clinic, it's going to turn out to be dementia with Lewy bodies, and people who end up in the movement disorder center with my colleagues who don't focus on thinking and memory trouble, it's going to turn out to be Parkinson's, but not always. And then to the far right, other forms of dementia, the term dementia means a decline in thinking and memory from this person's baseline, not anybody else's, this person's baseline, that is affecting their day-to-day function and independence. That's all dementia means. You can have dementia for hundreds of different reasons. The most common question I get in my clinic is, what's the difference between dementia and Alzheimer's? Aren't they the same thing? No, dementia is the umbrella. Alzheimer's is just one kind. There are many, many other forms of dementia, some of which are treatable and reversible, some of which are not yet, though we're working on it, and are neurodegenerative and progressive. And this gets even more complicated because most people with Alzheimer's, especially later in the course of their disease, also get some degree of Parkinsonism. And then that frontotemporal dementia category also includes the tauopathies. We have very difficult jobs as neurologists until we get better tests that tell us these things. So a different way of looking at this from the dementia standpoint, and this is how I train our neurologists who are becoming dementia specialists, as well as our medical students, is separate from the Parkinsonism question, thinking about it as an approach from dementia. People often end up in our clinic with a Parkinsonian disorder, but they don't notice the Parkinsonism. And so we have to keep that open mind of, what is the person noticing? What is the person who knows them best noticing? And then what are we noticing as the unbiased outward observer? And all of our expertise triangulating those three very unique perspectives and points of view to figure out what is going on inside this person's brain. And as we see here, even when we're approaching this from a dementia standpoint, not from a movement disorder standpoint, that FTD, frontotemporal dementia, Parkinsonism, the progressive supranuclear palsy and cortical basal degeneration are under this umbrella of frontotemporal dementias. Now, MSA, multiple system atrophy, is not on this list because traditionally people don't get a lot of thinking and memory trouble with MSA. But as we'll see at the end, if you look for it, it's actually usually there. And so instead of these beautiful separate flow diagrams and categories, there's way more overlap with these things. And this is actually what led me to do additional training, because looking at it from just one lens is just a movement problem of just a motor strength problem or just a thinking and memory problem, you might miss some of these aspects and the overlaps of this Venn diagram in here. So somebody comes in with Parkinsonism. We won't look at this from the dementia lens because this is the Movement Disorder Center Symposium and not our Dementia Center Symposium. But somebody comes in with Parkinsonism, slowness, stiffness, shakiness. What are those red flags to us that this might not be typical Parkinson's disease, that there might be a separate condition going on? Rapid progression, months to a few years rather than many years. From the time we meet the person to when we see them back in the clinic, they look very different to us. Huge red flag. Very early or prominent speech and swallowing difficulty, early falls and freezing, and then that the dopamine medications do not work for them. Sometimes it works early and then it very quickly wears off. So we're always, again, keeping one eye open. Are we in the right category of conditions for this individual? So let's go through the 3 atypical Parkinsonian disorders individually, starting with progressive supranuclear palsy. So this is probably a lot more common than we think. These 3 conditions are usually taught as rare. Atypical makes you think it's more rare. We do this with Alzheimer's too. There's a few forms of atypical Alzheimer's, but they're probably more typical and common than we actually think because we're just not looking for them and people aren't aware of them. Up to 5 out of every 100 people with Parkinsonism probably has PSP. It starts a little bit later than typical Parkinson's disease. It's equivalent between men and women, whereas Parkinson's more common in men. And it has a much shorter life expectancy than Parkinson's does. And usually the cause of death, falls, injuries, choking, swallowing difficulty, or pneumonia, food going down the wrong pipe. So what are those extra things that comes with the Parkinsonism in people with PSP that we're looking for? It's the very early gait dysfunction. People are falling very early. And in that table there on the right-hand side of the screen, PSP being the top one, that on average, from the start of noticing any trouble with moving their body to having those very frequent falls is only about 1.5 years. Whereas at the bottom, the blue line there for people with Parkinson's, we're talking about many years before we're seeing those frequent falls. What we'll often hear from people, especially from their partners, is they fall and they don't even attempt to catch themselves. They go down like a tree trunk. And it's because those postural reflexes, the ability to catch yourself, you slip on ice, your spinal cord actually keeps you upright before you even are aware that you're falling. They lose that. And that's that really rude test that we do in the clinic where we tell you we're going to pull you back by your shoulders and we ask you to catch yourself. So people with PSP don't even try to catch themselves very frequently. And that's why we always have a wall behind us so you don't smush us. In addition to the trouble with falls and that postural stability, there's changes in eye movements, especially eye movements up and down. And so that also contributes to the falls. If people can't look down and see that uneven curve that they have to step up on, or they catch their toe on the rug, or they're going up and down the stairs and they misjudge it, that leads to the falls. And then we often hear from people difficulty reading, especially following lines of text as they're reading because their eyes are not moving easily and automatically. Eyelid opening apraxia is another thing that can happen early in people with PSP. And sometimes you'll even see people with their eyes at rest, just closed, and you think they're falling asleep, but they don't even realize their eyes are closed. And we'll do Botox sometimes to help them open up their eyes. Usually people that end up in my clinic, in the thinking and memory disorders clinic, that turn out to have PSP, they're more worried about their thinking and memory. And they may not even be noticing trouble moving their body. Everybody that walks into my clinic tells me it's their memory, or their partner says it's their memory. And my next question is always, what do you mean by that? Give me some examples. Because more often than not, it's not actually their memory that's impaired, it's other parts of our cognition. Things like our executive function, planning, multitasking, making decisions, following steps of instructions, or especially in PSP, language difficulty, finding words, producing the words, pronouncing the words correctly. People with Parkinson's can get similar changes in executive function, but they almost never get the speech and language trouble that people with PSP do. And PSP overlaps quite significantly with another form of frontotemporal dementia called primary progressive aphasia, PPA. So it's primary language problems, and they don't have the movement trouble per se, but more often than not, we get a little mix of both. So when we're testing somebody with Parkinsonism, and we hear about early falls or we see eye movement abnormalities, a little test we can do is ask the person to tell us as many words as they can think of that start with a certain letter. So tell me as many words as you can think of that start with the letter F, the letter S, the letter B, and I'm going to give you 60 seconds to do it. Normal is about 11 words in a minute. People with PSP almost always produce 7 or fewer words. And so that can help us differentiate Parkinson's from PSP with a pretty easy 1-minute test. In addition to coming up with unique words, actually forming those words with the mouth, with the lips, with the tongue, with the throat, they can also have trouble there where the words come out distorted and it looks like they're incoordinated with their mouth movements. That's called apraxia of speech. And the way that we test that in the clinic is we ask people to pronounce difficult to pronounce words, kind of tongue twisters, to see how their mouth is forming those words. Along the lines with the executive dysfunction is also disinhibition and poor judgment. People with FTD also have that, and they can often get in trouble. They're doing things that they probably shouldn't do in terms of getting in trouble with the law and poor judgment that way. Usually not so much with PSP. They're just not thinking through their choices in terms of safety often. And so what we see is something called the rocket sign. So we open up the exam room door, we introduce ourselves, and the person jumps up out of their chair very quickly to say hi to us and shake their hand, and they fall right back down into the chair. Or when we're having them walk down the hallway so we can see what their gait looks like, they'll very quickly turn, kind of like a pirouette turn, and fall over rather than the kind of slow, gradual turn that most people with Parkinson's will do to keep their balance. Pseudobulbar affect is inappropriate laughing and crying in situations that don't have an emotion tied to them, comes from brainstem dysfunction. And then something called perseveration, where people get stuck, like the record keeps skipping. And so we'll look for something called the applause sign, which is we tell them, please clap 3 times, just 3 times, and they'll just keep clapping, they get stuck. And echolalia is they'll repeat things over and over and over again, kind of like a skipping record. Oftentimes when we walk into the room and we see them jump up out of the chair to say hi to us and fall back down with the rocket sign, we'll also see this, which is called the Procerus sign, which is overactivation of the muscle between our eyebrows here, which gives them this very worried or astonished look. And also the nasolabial folds here around the mouth can be very deep and furrowed there. And then we can also see when people are up and around walking something called the gunslinger sign. So people have decreased arm swing in most of the Parkinsonian disorders, but in people with PSP, the arms are kind of held back and extended, just like in old Westerns where they're about to do, the shootout and they have their hand ready and waiting over their gun. To diagnose PSP, it's kind of like a Chinese restaurant menu where we have to go through and see how many of these different features are present. And as you move from 3 up to 1, that increases the level of confidence of the diagnosis of PSP. Usually the first few times we meet somebody, we're not going to check a lot of these boxes. We'll be worried. We want to keep an eye on them. But it's rare that somebody checks all the ones across the board early on, and these things can become more prominent over time. We can also get MRIs of the brains of people with PSP looking specifically for something called the hummingbird sign, which is that part of the brain circled there in the white box, that the midbrain, which is the little bird's head up there, the pons, which is the bird's belly. And so you will see that the head of the bird starts getting smaller and smaller, and his beak gets narrower and narrower over time. Again, this isn't always present on early scans, and so we might not be able to appreciate that early on. We get scans down the road as people start to look more and more like a PSP phenotype, and we can see it come later. And then on the cross section there of the bottom slides, either the Mickey Mouse sign or what's called a morning glory sign, where the midbrain with the two little ears on Mickey Mouse's head kind of spread apart there, and his head gets a little bit smaller over time. Just to let everybody know that there is going to be a large clinical trial that's national. We are going to be a site with several other large academic institutions across the country for PSP. And this is copying what's been a very successful, at least in terms of efficiency. They haven't had many successful treatments come out of it yet for the ALS platform trial, where because it's relatively rare, these are hard studies to do. Instead of doing one trial, waiting, seeing did it work or not, to combine forces and put people with PSP into many trials very quickly, and that if it's not seeming promising, moving on to the next one. And so things are a bit of a mess right now at the NIH. We're waiting for things to get started. They've chosen 2 of the drugs that will be the initial treatments trialed for people with PSP, and they're choosing a 3rd, but more to come on this hopefully in the very near future. Moving on to cortical basal syndrome and degeneration, less common than PSP, usually a little bit earlier in onset. And probably the most predominant feature of this is that it's very, very asymmetric. One side of the body is very impacted and the other side might be completely normal. There is the Parkinsonism of slowness, stiffness, and shakiness, but there's a lot of other changes in how the body's moving too, as well as a lot of changes in thinking and memory. So again, these people sometimes end up in the memory clinic rather than the movement clinic. We call it corticobasal syndrome while the person is alive because we don't have proof that it's actually degeneration until autopsy. And so corticobasal syndrome can be due to corticobasal degeneration, which is one of those tauopathies in the same family as progressive supranuclear palsy and other forms of frontotemporal dementia. But you can have a corticobasal syndrome because of Alzheimer's changes in your brain, or dementia with Lewy bodies, or prion diseases like mad cow disease in the 80s. Or you can have corticobasal syndrome because you have progressive supranuclear palsy. We have tough jobs. Hopefully those biomarkers come out soon and help us figure this out better. But what we're looking for to know we're in this category of corticobasal syndrome is that the parietal lobe, which is the top back part of our brain, it's very important for processing of information, both inside of our body, our external world, that has the most difficulty. And as we'll see on the next slide, the most shrinkage on a brain scan. Usually somebody with a corticobasal syndrome, again, one side very, very affected, the other one not. While people with Parkinson's always start on one side and it always stays worse on that side, the other side always gets affected too, but not for people with corticobasal. And so they'll have a lot of dystonia, extra muscle tightness and rigidity. Usually they'll come in with one arm even kind of held up in flexion like this. And then a lot of trouble with motor planning and programming. Using tools, knowing how to manipulate things is very impaired. And this is an example of an MRI of somebody with corticobasal degeneration where those parietal lobes, this is the top back part of the brain, are the most affected, and one side is much more affected than the other. Multiple system atrophy being the last atypical Parkinsonian disorder. This one usually doesn't come to me. Usually they're not noticing or bothered by any thinking and memory trouble, but again, if we look for it, we often find it. And often these people aren't even ending up in the movement disorder center. They're ending up at the GI doctor, at the urologist, at the cardiologist, because the symptoms of the autonomic nervous system, all those automatic functions in our body, like our bowel and bladder function, our sweating and temperature regulation, our heart rate and blood pressure, our sexual function, those are the things that are happening early on, and there might not be Parkinsonism early. A lot of the times, referrals are sent to us as possible multiple system atrophy, but more commonly, it's Parkinson's still. Everybody with Parkinson's also gets some degree of autonomic dysfunction. The difference is what comes first, what's the most prominent. And so when you look at autopsies of people with multiple system atrophy diagnoses in life, up to 1/5 of them had Parkinson's disease. People can also have a lot of trouble with their swallowing and with their voice and speech, but it's different than what we see in the progressive supranuclear palsy, where it's more the throat muscles than it is the mouth muscles. They can also have dystonia, those extra muscle contractions, and it's usually a forward tilting of their head. We'll see a picture on the next slide. Their big toe goes up. These things can happen in other Parkinsonian conditions too, but it's happening early. And then very cold and blue feet. And so there's an example on slide A of the cold blue feet. B is what's called the striatal toe, which is tightness of that big toe going up. And then that anterocollis, that forward flexion of the head and the neck. Multiple system atrophy is split up into two subtypes, either predominant Parkinsonism, slowness, stiffness, shakiness, or cerebellar features, usually with more ataxia in coordination. The MSAP subtype usually does have more thinking and memory trouble, and it looks like what we see typically in people with Parkinson's with cognitive changes. With the MSAC, usually more inattention. And they also have some unique MRI findings, which we call the hot cross bun sign, a picture there of much more popular in the UK than the United States. But deep in the brain there, you see these changes with that kind of cross. Again, you don't always see it right away, and you might have to wait until the person's more symptomatic to find these things. Before, if somebody had thinking and memory trouble, it was an exclusionary criteria for diagnosing MSA. But again, the more you look, the more you find. And sometimes you just have to do the right test to look for it. Again, usually in MSAP, the thinking and memory trouble is that executive function change that we see in people with Parkinson's as well as PSP. And the MSAC a little bit more inattention, but their executive function seems fine. And that's why MSA wasn't on that subtyping of Alzheimer's versus the Lewy body versus the frontotemporal dementias, and why they usually don't end up in our memory disorders clinic. So that was a very quick overview of these three other conditions that we're always thinking about and looking for and making sure we're not making an inappropriate Parkinson's disease diagnosis, because not all slowness, stiffness, and/or shakiness is Parkinson's. And that when the brain is changing in these ways with the loss of neurons over time, it doesn't always follow the rules of just this change in this person. And there's very frequently overlap of movement, thinking and memory, and behavioral changes. But if we see extra things, if we see people aren't responding to the typical treatments, and they're progressing much more rapidly than we would expect for somebody with typical Parkinson's, we need to think about these other conditions. If I come back and give this talk again in a few years, it might be very different as we get better tests to understand what exact change is happening in this person's brain, and that we define diseases biologically rather than by combinations of outward symptoms. But we do the best we can right now, and always make sure we're treating the person in front of us and not necessarily a label or an acronym. With that, happy to answer any questions. I know it's the end of the day. You probably want to get out of here, but I'll also stick around if there's other questions about thinking and memory. Thanks so much.